We are recording now, and this audio recording will be broadcast and electronically manipulated by Vertical Internet Radio. And is that something that you give us permission to do with this audio file?
Yes.
Right. Hello and welcome to Health Professional Radio. I'm your host, Neal Howard. Thank you so much for joining us today. You know, many of our young women are struggling with many issues, not the least of which is body image issues. Some of these issues often lead to eating disorders and other problems. Our guest in studio is returning to speak with us today, Dr. SooMi Lee-Samuel. She's medical director of Timberline Knolls Residential Treatment Center and also board-certified psychiatrist. Welcome back, and thank you for coming back, Doctor.
Thank you for having me.
Thanks. You know, we were here before talking about your role at Timberline Knolls. Talk about Timberline and what are you involved in there?
Sure. So I'm the medical director of Timberline Knolls. We are a residential treatment facility that services adolescent girls and adult women from the ages of 12 on up. And we treat women and adolescent girls with eating disorder behaviors, with trauma, a history of trauma, with mood disorders, and with substance use issues. Generally, we find that a lot of our women have more than one disorder, and so that's why we try to specialize in treating multiple disorders simultaneously as opposed to isolating them and treating them separately.
Okay, that's understood. Do you find that your patients come in for the eating disorder and then other things are revealed, or does it matter not what they come in for? You just treat?
I think it goes both ways. We have some women who come in with a known eating disorder, and as we're working with them, we start to address things that have gone on in the past. For example, there might be a trauma history or an abuse history that was never really addressed that may be contributing to the eating disorder, and that connection was never made. Sometimes we have women come in with mood disorders or depression, and they've been hospitalized multiple times, and as we're treating that, we also start seeing that, they also have disordered eating, but that was never really addressed. So a lot of times they may come in with one thing, or they may come in knowing that they have a couple of things going on. Either way, we try to do a very comprehensive assessment so we can try and be cognizant and mindful that there may be more than one thing going on, whether or not it's actually brought to our attention at the time of admission.
Are your practitioners there each in specialties, or do you have to move your client's case from practitioner to practitioner based on their progress or the lack thereof?
Right. No, we have an amazing group of staff members here. So all of our psychiatrists, we have 8 on staff, and we are all of us are board certified, and we actually have 5 who are child and adolescent psychiatrists who are board certified as well too, myself included, and we actually have an addiction specialist. And then in addition to the psychiatrists, we have therapists who are trained in various specialties, including trauma awareness, in domestic violence issues, in eating disorder issues, and in mood disorders and OCD. So if someone comes in, let's say, presenting with a history of eating disorders, but also has a history of obsessive compulsive disorders, we'll try and match that person up with the team that we think will best serve her needs and will best, be a good fit for that particular person.
What about collaboration between your facility and facilities that your client may have been involved with in the past? How seamless is the sharing of information, especially when it comes to the benefit of these young patients?
Right. At our facility, we recognize that the women are only with us for a short time. They're with us for maybe 4 to 8 weeks. And so when they come into our facility, we identify who the referral source is, and then we also identify within the first 48 hours who they are going to be returning to after they leave our facility and what to do for aftercare. We actually have a specific aftercare program made up of 12 therapists whose sole job is to ensure that the aftercare for our individuals is set, and that means doctor's appointments, PHP programs, IOP programs, everything that it takes to make sure that once they leave our facility and they're discharged from our facility, that the next step is going to be a very seamless it's going to be very seamless, and it's going to be very, very easy for the individual.
Now, it seems as though you're not only well-rounded in all of these different areas. When you're treating your patients, are you treating them, I guess, from a specific medical, psychiatric standpoint? Are there other issues, that come into play as well based on that person's, cultural beliefs or background?
Mm-hmm. So, for example, we have a Christianity track. So we may have some women who are requesting a Christian team and a Christianity track program. And what that entails is that they will work with team members who are Christian, who have Christian-based therapies in their background, and they have special groups like spirituality. There's a group that's dedicated towards understanding God and religion. And so these are groups that not everyone will have here on campus, but those who request that track can request it. And so what we really try and do is we truly try and individually tailor the program according to what that person would like, but also what the treatment team feels that that person needs. We've had some individuals where the parents requested one thing, but it's an adult woman, and she wanted something else, and this was her trying to make a voice for herself and empower herself. So that's a situation where our family therapist would be involved and be the communicate with the family. Listen, this is what you wanted, but this is what your daughter wants, and so this is what we're going to do for her, so that we're all on the same page. In the end, it really is what the individual wants, but also what the treatment team feels is going to be the best program for that individual.
How prevalent are eating disorders, and how prevalent are eating disorders that go along with something else?
Eating disorders, the epidemiology of eating disorders, there was one study that thought that the prevalence was about 5 to 10 million females, and 1 million males in the U.S. met some kind of diagnostic criteria for an eating disorder. The most common one is this eating disorder not otherwise specified, where they have disordered eating behaviors, but they don't specifically meet criteria for bulimia or anorexia. Following this eating disorder NOS criteria diagnosis is bulimia, and then following that is anorexia. What's significant to note about the eating disorders, though, of all the psychiatric disorders out there, this includes schizophrenia, bipolar disorder, depression, anorexia has the highest mortality rate of any of the psychiatric disorders. And so it's not the most commonly occurring. For example, anxiety disorders are much more commonly occurring in the general population, but the most lethal diagnosis is anorexia. And usually death occurs from suicide and not from malnutrition. So there's definitely this comorbid and co-occurring diagnosis of that we see depression, we see substance use, and we see PTSD along with eating disorders, and it's very common to see.
So when you have someone who's coming in and they're suffering severely with maybe PTSD or something else, in addition to this eating disorder, can they stay as long as they need to stay, or do sometimes other steps have to be taken based on their progress or the lack thereof?
Right. I think sometimes the most important thing is to make sure that the patient is medically stable. And we have to make sure that they're medically stable. If they're not medically stable and they're unstable, then they're going to have to be transferred to a higher level of care, like an inpatient hospital setting. And that's just for the patient's safety. And so it requires us to collaborate with hospitals in the area to make sure that the people who come into our facility are at the right level of care.
When there is progress, what about follow-up and, making sure that things are, still working for the client? Is that something that is included, or is that something voluntarily that the client offers?
No, absolutely. So as I mentioned before, we have our aftercare department. And so the ideal is that once someone completes residential treatment programming, they would step down to partial hospitalization, a PHP program. And our recommendation is usually 2 to 4 weeks in PHP after they've completed residential. After PHP then would be probably IOP, which is intensive outpatient programming, or appointments with your outpatient team and outpatient providers. Once someone leaves our facility, it's not like they can return home. We think that it's too much of a jump, and it's too jarring for someone who's been living in our facility for 24/7 to then suddenly return to their day-to-day programming. I think it's going to be too much of a shift. And so that's why we offer and we recommend the PHP program, which is a step-down program so that people can engage in programming during the day, but in the evening they are able to sleep in their own bed. They're able to go home. Now, we offer a PHP program at our facility as well, too, and we actually offer housing. So it offers people a chance to participate in day program on our campus, but then they can go to, it's like a boarding house, and they can sleep in that house with other women who are in the program. So they are kind of on their own, and they're acclimating back to the real world. Like they could go to the grocery store if they wanted to. They could go to the pharmacy. They can do their daily errands, and so they can start doing some of their day-to-day routines again, but still be in a structured program so that they feel like they're being supported while they're managing their behaviors.
Where can our listeners go online and get more information about Timberline Knolls Residential Treatment Center?
Absolutely. You can go to our website at www.timberlineknolls.com or call us at 1-844-335-1932.
It's been a pleasure, Doctor.
Thank you very much.
Thank you. You've been listening to Health Professional Radio. I'm your host, Neal Howard, in studio with Dr. SooMi Lee-Samuel, Medical Director of Timberline Knolls Residential Treatment Center. Transcripts and audio of this program are available at healthprofessionalradio.com.au and also at hpr.fm, and you can subscribe to this podcast on iTunes.